It's not a cut, it's simply a way of doing what we do for the same amount of money. Now, you might say, well, that's really tricky. How are we going to handle that? And it is really tricky, and I don't know how we're going to handle it. So I'm going to put to you some thoughts. We know that in the private sector, successful companies have three attributes. The first is that they have very tight fiscal controls. They understand how their money is spent. Secondly, they listen to their customers. And thirdly, they innovate. And that innovation is focused almost entirely on what their customers tell them they want. The public sector, on the other hand, adopts a totally different attitude. And we've seen this time and time again. The public sector buries its head in the sand, seeks the security of the status quo, and waits for the storm to pass. This storm is not going to pass. As Warren Buffett said, if you have hot water at one end of a bath and cold water at the other end, it's not long before the bath is all one temperature. We cannot look over towards the east end of the city and see huge financial problems and expect the NHS to be free of the impact of that. What we need to do, we need to find a solution to that. So the solution is we need to do more work for the same amount of money. We need to be smarter. I consistently hear the argument that in healthcare, if you want quality, it's going to cost you money. Well, I'd like to challenge that thesis. In my specialty, that certainly doesn't hold true. A colleague of mine looked at the cost of coronary artery bypass surgery in all hospitals in Virginia. And he looked at the risk-adjusted outcomes, and they looked at the cost in relation to the risk-adjusted outcomes. And all units in Virginia, when compared with their national database, were better than the national average. But the difference in cost between a hospital that was good and a hospital that was excellent was 30%, with the excellent hospital being 30% cheaper. And put in real terms, that was about $30,000 versus $20,000. Why? It makes intuitive sense to surgeons. Better operation, less time in ITU, fewer complications, out of hospital sooner. And actually, the cost can be transferred further into the community because those people get back to work sooner. So the argument that quality has to cost more in healthcare must be challenged. And I think surgeons are in a unique position to challenge it because the evidence base is beginning to grow. And we're starting to draw this up with dice at the moment. We have evidence that better quality care is cheaper in issues ranging from the sorts of interventions which I alluded to right through to pediatric operating room. In many places, the evidence is pretty shaky, but we need to grasp the nettle of where the evidence exists. Why is it that we live in a technological age that every year we expect a new model of a car to cost about the same but to have better specifications? Why is it that a laptop down at PC World, a good one, generally costs about £1,500, and every year the specifications are better? But in healthcare, if we want to improve the specifications, it's got to cost more. It's a mindset issue, and it's getting underneath that mindset, I believe, is where the solution lies to this particular problem. Now, in Tesco's, which is a large dispersed organization in some ways like the NHS, a shop manager can do what he or she likes in their shop without recourse to higher authority, provided they can demonstrate that what they do is better, simpler, and cheaper. And actually, for those of us who have to run and provide services, that's not a bad mantra. And it's certainly something which would provide a very useful platform in the development of any business plans. So, innovation in the NHS is, I believe, where the solution lies to many of our financial challenges. But innovation is not just about robots and nanotechnology. It's about the overuse and the underuse of treatments. It's about providing the right treatment to the right patient at the right time in the right environment. It's about service redesign and elimination of waste. Why is it that in some hospitals in this land, and indeed even in the city where I live, you can go into one hospital with a breast lump and be told to come back 3 or 4 times for various investigations before you get a final plan? And you can go into another hospital only a few miles away and you can leave a few hours later with a diagnosis, a care plan, and a date for your surgery. Why do we have that level of variation? That level of variation costs money. Macmillan have done a huge amount of research into the cost of cancer care, and they're about to publish some stuff from Manchester, which shows that in lung cancer and breast cancer, that about 50% of the cost is on about 10% of the patients. So I said, well, those must be the complicated patients. And the answer is no, it's not the complicated patients. It's the patients who get caught up in the system, which is poorly designed, and people who bounce around like a ball in a pinball machine. Those are the people who cost money. It's not necessarily the severity of the disease, although frequently that makes a major contribution. Why is it that in a service organization, that our operating theatres for elective care partially empty on a Friday afternoon? There are all sorts of answers for that. But why are they empty routinely on a Saturday and a Sunday? Does that make sense in an industry which is funded by the taxpayer for the service of the taxpayer? I think we need to start challenging all these kind of historical practices. Now, clinical innovation, though, is about discovery. It's about the practical application of that discovery. And finally, it's about the uptake of that discovery by our colleagues. And SARS, I think, has a unique place to play in this, because I think clinical academic leadership is vital to the success, not just of the NHS now, but it's vital to the training of the next generation, and it's vital to the development of services. But to what extent do the organizations such as SARS and organizations which I've been part of actually follow some of the stuff through in terms of facilitating rollout? Why does surgical spread, or indeed any kind of best practice spread in healthcare, take so long? You know, the average length of time from something which is based on a hard evidence base being presented, if you like, to the healthcare community and being in widespread practice is about 15 years. That's bizarre, isn't it? I can give you examples of that. The use of the internal mammary artery as a prime bypass and coronary bypass. So that's taken about 15 years in this country. The spread of minimally invasive surgery has taken a long time. The development of hip replacement is likely to take a similar length of time, and we're looking at ways to try to speed that up. What about prophylaxis for venous thromboembolism? The evidence base of that's been around for about 30 years, and we have a pretty shocking track record in the application of that within the NHS. So, on the scale of professional morality, this isn't right. And it's up to us, I believe, as clinical leaders to start addressing that variation and the slow speed of uptake of best practice, because collectively it's not fair to our patients who trust us to offer them what they believe we think is best. And when some people are doing something that it takes others 15 years to adopt, I think we have to search into ourselves as a profession and ask why that's the case. So I put it to you that leadership is really the issue here. Now, leadership underpins any kind of large-scale change, and the NHS is going to require some very large-scale change over the course of the next few years if we're going to successfully navigate some of the challenges which are facing us. One of the fundamental truths about large-scale change is that if you want it to happen, and if you want it to be sustainable, that the people who you are asking to change need to believe that that change is worthwhile. And in healthcare, that boils down broadly to two things. It needs to either make people's life easier, or they need to believe that it's the right thing to do because it improves the service that we offer patients. Now, That's all very well, but it requires an enormous contribution from effective leadership. Our NHS is a big system. It's not an organisation. It's a system which is basically compiled in a federal way, if you like, of a bunch of semi-competitive, semi-autonomous organisations who are, broadly speaking, aligned in the same direction, but not always as aligned as they might be. It employs about 1.4 million people, sees 1 million patients every 36 hours, consists of acute care, primary care, mental health care, dentistry, opticians, pharmacy, ambulance trusts. So it's quite a complex organisation. And the people who are meant to provide the managerial leadership are essentially the people working in Whitehall for that, for the system management of this complex system.